Hello, everyone. Today I'll be discussing the ultrasound examination of two structures seen in the pelvis but beyond the uterus and the ovaries. And why is this important? This is because there are certain conditions, for instance, endometriosis or even gynecological malignancies, when we need to examine the pelvis in much more detail and need to go beyond the uterus and the ovaries. Also, certain non-gynecological pelvic pathology can present with pelvic pain and mimic gynecological pathology. So, in order to be able to identify these non-gynecological conditions, we need to be able to image certain pelvic structures using transvaginal ultrasound. Now, first, I would like you to become familiar with the appearance of the normal bowel on ultrasound. As you can see in this image, this is a transverse section of a collapsed bowel loop. And a collapsed bowel loop, I've used a high resolution ultrasound probe here to show you the typical gut signature or the normal layers that we can appreciate within the bowel on ultrasound. Now, the echogenic layers that we see are the mucosa and the submucosa, whereas the hypoechoic layers in the bowel wall comprise of the muscle, the inner layer being the muscularis mucosa and the outer layer being the muscularis propria. Now, in this case, again, this is the bowel loop, but it is partially distended due to presence of fluid and some food debris. And in this case, we can still appreciate this hypoechoic muscular layer. Now, what I want you to do is to become very familiar with this regular smooth appearance of the hypoechoic muscularis propria in the bowel wall, because this is something which will be affected or infiltrated in a patient with deep infiltrating endometriosis. And all that you have to do is keep a close watch on this layer when examining a patient for nodules of deep infiltrating endometriosis. Now, if I rotate my probe 90 degrees from this transverse section, I would get a longitudinal section of the bowel as I am here. And here you can appreciate that this is the normal bowel lumen. As you can see, it is in the form of a tube. It is again partially distended because of presence of food debris in the lumen. And we can appreciate this smooth hypoechoic muscularis propria in the bowel wall, giving a kind of tram track appearance. So this is the appearance of the normal bowel wall in the longitudinal section on ultrasound. Now let's come to the examination of a structure in the posterior compartment, that is the rectum. The anterior wall of the rectum, mainly the muscularis propria and the anterior wall, is a common site of infiltration by deep infiltrating endometriosis. And that is why it's important to be able to understand the normal appearance of the anterior rectum using transvaginal ultrasound. Now, as we've discussed earlier, the ultrasound examination begins as soon as we place the probe on the introitus. And this is the image that I've obtained by placing the probe on the introitus. But when we scan for the uterus and the ovaries, this is how we place our probe on the introitus. The probe is directed towards the vagina in such a manner that we go in at 90 degrees to the endometrial cavity so as to get the best possible image of the uterus. But when we are interested in examining the posterior compartment, that is the rectum, we would place the probe at the introitus but angulate it posteriorly towards the sacrum, as you can see from this arrow. So I would still be placing my probe at the introitus because I'm going to do a transvaginal scan, but the direction of introduction of probe would be such that it would be going towards the sacrum because I'm interested in seeing the anterior rectal wall. So as you see here, when I place my probe at the introitus, which is directed towards the sacrum posteriorly, then this hypoechoic thing that you see just touching my transvaginal probe is the vaginal wall. So this here is the vagina. And behind the vagina, so this is my anterior, this is the urinary bladder anteriorly, this is the vagina, the wall of the vagina touching the transvaginal probe, and behind the vagina would be the anal canal. So if you appreciate here, this is a longitudinal section of the anal canal. You can appreciate the hypoechoic muscular layer anteriorly and posteriorly, and the echogenic lumen of the anal canal. So this is the kind of image that you would get if you have directed your probe correctly towards the posterior compartment at the introitus. After this, I would gently introduce my probe into the vagina making sure that the probe goes into the posterior fornix because I'm interested in scanning the posterior compartment. I would keep a close watch on this hypoechoic muscular layer because remember it is the anterior muscular wall of the rectum, which is the common site of the nodules of deep infiltrating endometriosis. So going back, this is the hypoechoic anterior wall that I would keep a close watch on while I'm introducing the transvaginal probe. Again, this is that anterior hypoechoic muscular layer. I hope you can appreciate it. This is the anterior hypoechoic muscularis propria. This is the vaginal wall touching the vaginal probe, and right behind it, behind this echogenic thing, is this hypoechoic anterior muscularis propria of the rectum. This is the echogenic lumen of the rectum, and all the time while you are directing your probe to see the cranial parts of the bowel, you have to ensure that this anterior muscularis propria is a thin, smooth line. So just keep a watch on this thin, smooth hypoechoic line. Now, if you see here, what happened? You see this hypoechoic line, but this echogenic content that you see here behind this thin hypoechoic muscularis propria is nothing but air in the lumen of the rectum. Why I say this is air is because it is casting distal shadowing. The shadowing is so dense that it is obscuring the posterior rectal wall. But when we are scanning for deep infiltrating endometriosis, we are really not interested in looking at the posterior rectal wall because that is not a common site for involvement. So it's okay even if there is air in the rectum because all that we need to see is the anterior hypoechoic muscular layer, as you can see here, the anterior hypoechoic muscularis propria. Now this is a longitudinal section of the rectum, but here now we've started seeing a transverse section. As you can see, this is the round transverse section, and again, note how regular, smooth, hypoechoic this muscularis propria is. This is the normal appearance of the rectum in the transverse plane. So again, just keep an eye on this hypoechoic muscularis propria of the anterior wall, and you have to look for any eccentric thickening of this wall when you are looking for deep infiltrating endometriosis. Now I've taken these still images from the previous clip just to illustrate and highlight the anatomy again. This is the transvaginal probe surface. This would be the vaginal wall, this hypoechoic layer. Then this hypoechoic layer, the second hypoechoic layer that you see would be the muscularis propria in the anterior wall of the rectum, which is our area of interest. The air in the rectum casting dense shadowing posteriorly. This is the longitudinal section of the rectum, and this is a transverse section that we are getting here. Note that the rectal lumen is collapsed here. Here there is neither air nor any fecal matter in the rectum. And so we can again appreciate that typical gut signature. As I said earlier, the hypoechoic layers on the inner side would be the muscularis mucosae. So this thin hypoechoic layer is the muscularis mucosa, whereas the thicker hypoechoic outer layer, which is actually our area of interest, is the muscularis propria. Now I have highlighted these two echogenic layers, one with yellow and the other with green arrow. This is for you to think and let me know as to what they are. So I've shown you the muscularis mucosa and the muscularis propria. Our main interest in DIE is the muscularis propria, but still you should be able to identify the other echogenic layers in the rectal wall. Again, this is another image, a bit longitudinal section. This hypoechoic layer on the outer aspect is the muscularis propria. On the inner aspect, this thinner hypoechoic layer in the rectal wall is the muscularis mucosa. And in between the muscularis propria and the muscularis mucosa, what is this echogenic layer? This echogenic layer is nothing but the submucosa. Again, a brief clip to give you an idea as to how the muscularis propria looks like. It's good to see the same thing over and over again because that helps us in familiarizing ourselves with the normal anatomy. As you see here, I've already started introducing the probe in the vagina. This is the vaginal wall. This is the surface of my ultrasound probe. And I would be looking here for the hypoechoic muscular propria of the anterior wall of the rectum. So I've already started seeing this hypoechoic anterior rectal wall. And I would just keep my eyes glued to this hypoechoic anterior rectal wall as I introduce my probe more cranially and trace this as cranially as possible. So you can see I've here obtained a longitudinal section of the rectum. So this is a longitudinal section of the rectum. This is the echogenic lumen of the rectum distended with air and fecal debris. This is the hypoechoic anterior wall, that is mainly the muscularis propria of the anterior wall. Note again, it's a thin, smooth line. This is normal. We can also see a part of the posterior, the muscularis propria and the posterior wall, because this area is devoid of air, so there's no shadowing. So we can see a part of the muscularis propria and the posterior wall. But for DIE, that is deep infiltrating endometriosis, our area of interest is this thin hypoechoic muscularis propria in the anterior wall. Just keep an eye on this as we trace it more cranially. So you have to trace it as cranially as possible whenever you are suspecting deep infiltrating endometriosis. And remember, if you happen to see one nodule of deep infiltrating endometriosis, don't get happy and stop there, because there might be another nodule higher up. So you have to trace the bowel as cranially as possible in its entirety. So when you practice looking at the bowel, try to trace it as cranially as possible up to the rectosigmoid or the distal sigmoid if possible. Now, this, as you appreciate here, is a transverse section of the rectum. You can see it is filled partly with fecal debris, so you won't see all the 4 layers, but all that we need to see here is this hypoechoic ring of muscularis propria, which is smooth, regular, not asymmetrically thickened. So I think by now you would have got an idea of how the rectum looks like and what we should be looking for when we are assessing the normal rectum. Let's move on to something else. Now, this is a still image that we've taken from the previous clip, just to show you again the longitudinal section of the rectum and to highlight how the normal muscularis propria should look like. So this is how a normal muscularis propria looks like in the longitudinal plane. And again, we are interested in the anterior rectal wall, that is the anterior muscularis propria next to the transvaginal probe when we are scanning a patient for deep infiltrating endometriosis. Now, you saw this image a few slides back, the transverse section of the bowel with some contents in the lumen. You could appreciate the normal hypoechoic muscularis propria. Just have a look at this image. It's been taken with a transvaginal ultrasound, and this echogenic thing that you see here is the lumen of the rectum, highlighted in red. This hypoechoic layer that you see around it, which is relatively uniform, smooth, is the normal muscularis propria. But if you look carefully, in this area, when you go around the muscularis propria, you see this asymmetric thickening of the muscularis propria, which is hypoechoic, and this thickening appears to be on the serosal aspect. It's not coming from the mucosal part, that is, it's not coming from the inside the rectal lumen to outside, but it appears to be an implant which is sitting on top of the serosal surface of the rectum and infiltrating into the muscularis propria. So this is nothing but an implant of deep infiltrating endometriosis. And this is what deep infiltrating endometriosis looks like. So since you know the appearance of the normal muscularis propria, you can appreciate that it is asymmetrically thickened here and conclude that this patient has got a nodule of deep infiltrating endometriosis. Now, I'll also be discussing a structure from the anterior compartment, and that is the ureter. Now, before I start with the scanning procedure for the pelvic segment of the ureter, what we need to be aware of is the normal anatomy of the ureter. And we understand that the pelvic segments of the ureter turn medially and enter into the posterior aspect of the urinary bladder in the region of the trigone, as you see in this illustration. Now, when we will scan the anterior compartment, that is the ureter, like we did in the posterior compartment case, when I place my probe at the introitus, I would direct it such that it is pointing towards the anterior compartment. So I don't see the posterior compartment or the anal canal in this image. What I see here is this is the area of the vagina because I'm still to introduce the probe in the vagina. I'm at the endometriosis. And what I will try to obtain is a longitudinal section of the urethra. So this is a longitudinal section of the urethra as it is entering into the urinary bladder. This is the urinary bladder filled with urine. It's good to have the urine partially distended while looking for the pelvic segments of ureter. And so it's recommended that you look for the ureter at the end of the transvaginal sonogram when you've seen the other structures, because by that time the urinary bladder would be partially filled. And so what you do is first identify the urethra going into the bladder neck, as you see here. And after that, you start introducing the probe, as I'm doing here, keeping in the midline section. So I'll just push in the probe and see what happens. So now the probe is going into the vagina. I'm going in more cranially. And what we have here is, because I'm in this plane, I'm going in straight. So I'm in the mid-sagittal plane. And as a result, what I'm getting here is the utrovesical fold of peritoneum. This is the posterior wall of the urinary bladder. This is actually the muscular layer, the hypoechoic muscular layer or the detrusor muscle layer of the urinary bladder. And this echogenic layer that you see is the serosa in the utrovesical compartment. Remember, I showed you the normal sliding or the positive sliding of the utrovesical compartment in the previous video. So this is the serosa of the utrovesical compartment. I'm still in the mid-sagittal section because if you see here, this is the uterus, this is the cervix, and we can just see the endometrial cavity. So I'm still in this mid-sagittal plane. But remember, since I am to see the pelvic segment of the ureter, if I continue introducing my probe in this plane, I will end up seeing the uterus and the ovaries. I will not be able to see the ureter. So in order to see the ureter, I would have to rotate my transducer and angle it towards the patient's right and left in order to see the right and the left pelvic segments of the ureter. So I'll have to turn or rotate or angle my probe like this. So as of now, I'm still in the mid-sagittal section, but now I'm going to start rotating and angling my probe towards one of the patient's sides. And now I've started rotating and angling the probe, and this structure, which I will see opening into the posterior part of the urinary bladder here, would be the ureter, because remember the ureter comes on the posterior wall. So once I have an idea that I've started seeing the ureter, this structure here, I will optimize my image. And how would I do that? I would reduce the sector width, I would reduce the depth, and this hypoechoic structure that you see here going into the urinary bladder on the posterior wall would be the pelvic segment of the ureter. So just have a look and you can appreciate the peristalsis in this hypoechoic structure. This is the normal ureter. You can appreciate the ureteric peristalsis. Also, if you note, you can see a pulsatile structure here, and if you switch on color Doppler, this pulsatile structure in the vicinity of the pelvic segment of ureter is nothing but the uterine artery. Then you can see the peristalsis here. What I like to do here is, in order to visualize the pelvic segment of ureter, I sometimes switch on the sepia color because that gives a very good contrast and helps in seeing this hypoechoic segment of the ureter much better. Also, switching on color Doppler helps, as you will see shortly. Now, here what I have done is I have changed the color to sepia. So as a result, the visualization of this hypoechoic pelvic segment is much better. And also by switching on color Doppler, I'm able to identify the ureteric jet. That is the urine jet, which is flowing from the ureter into the urinary bladder. And it helps me confirming that this structure is indeed the ureter and not any vessel. So I'll just repeat this for you. Here, I'm placing the probe at the introitus, making sure that I see the urethra entering into the urinary bladder. And then I push my probe into the anterior fornix here because I have to see the anterior structure. I'm still in the mid-sagittal plane because I'm seeing the utrovesical fold of peritoneum. And once I see that, I will start rotating and angling my probe towards one side as I've done here. And I will see this hypoechoic segment, which is the pelvic segment of the ureter opening into the posterior wall of the urinary bladder. So now this is the ureter. I have started seeing the ureter, so I will optimize my image so that I see this ureter much better. I will reduce my gain a bit, decrease the sector width, and decrease the depth. And you can appreciate the peristalsis in this ureter very clearly, which confirms that this is the ureter and nothing else. But if you still want to be more sure, you can turn on the sepia color see the ureter in contrast much better, and of course, switch on color Doppler to identify the ureteric jet. So, what is the utility of identifying the pelvic segment of the ureter? Now, this was a patient who presented with lower pelvic pain, and on transabdominal sonography, the kidneys appeared fine. However, she could not fill her bladder well because of the excruciating pain. And since there was a suspicion of ureteric calculi, we went in transvaginally. So, you can see this was done at 10:09 a.m. and 4 minutes down the line, I went in transvaginally. And lo and behold, we could easily see the lower ureteric calculus, as you can see here. This is the echogenic calculus seen in the lower part of the ureter and upstream dilatation of the lower end of the ureter, secondary to obstruction by this calculus. So we can use the knowledge of seeing structures beyond the uterus and ovaries even to identify a non-gynecological pelvic pathology. So I hope by seeing this short presentation, you will now try to look for the normal rectum on ultrasound as well as the normal pelvic segment of the ureter. It will take some time, require some dexterity, but please be patient. You can have a look at the video again and again, and please practice because that's the only way to go. And if you're able to image the ureter and the rectum, please let me know. Thank you.